Little thing. Great. Thanks, everyone. My name is Abisoye Akintimehin, or Abby. Everyone calls me Abby. And I'm currently an internal medical trainee here in South London. I hope you can hear me just fine. You can't hear me. Okay. Can anyone hear me?
I can hear you.
Oh. Okay. Panicked there for no reason. Good. I don't know what to do about the others, sorry, but I just have to carry on. Maybe if you restart again, it might work. So I'm one of the internal medical trainees here in South London. I'm just going to take you through gastroenterology single best answers for final. So I'm going to focus mostly I'm going to focus the questions or the topics based around final year. So there might be people who are not in final year, but we'll just kind of focus on students who are going to be F1s. So let's get started. If you have any questions, just put it in the chat group and then we'll get through to them at some point, probably at the end of the session. Okay, so we're going to review liver cirrhosis, liver failure, IBD, celiac disease, IBS, upper GI bleed, inflammatory bowel disease, ascites, jaundice, gallbladder, colorectal cancer. Not everything's going to be in detail. Probably we'll focus more on the top 3 just because they're a bit more common and you're probably more likely to be asked them, but it's just good to kind of quickly glance through the other questions. Okay, so we're just going to quickly touch on liver cirrhosis. So liver cirrhosis is something so I guess when I was in medical school, the most important thing, one thing that I realized is that you get so much information and you don't actually realize what people think is important. And liver cirrhosis is one of those things that's just going to keep coming up and up again. Oh, still people can't hear me. And the sound is quite crackly. Okay, don't really know what much I can do about that. Sorry, guys. I just have to crack on. So, right. Can you just confirm that you can hear me? Sorry again.
Yeah, I can hear you fine.
Okay,
people are asking for the Zoom link, so I'll do that.
Let me know if you can't, and then I'll stop. But I'm just going to trust it. I'm just going to carry on. I won't stop anymore then. Okay, so right. So everyone focuses on what's important, and you get so much information in med school, you never really know what's important. Liver cirrhosis is one of those things that's important, and not just because I really like gastroenterology, but because it just comes up again and again and again. You see it on the acute take, you see it on, in clinics, you see it everywhere really. So with liver cirrhosis, so again, as final year students, you know that the liver at this point is pretty much damaged. It's not going to be reversible. And all you can hope for at this stage in the patient is that they don't add any further insults to the liver. So things like drinking or hepatitis, etc. So either when you've got liver cirrhosis, either the liver is compensated, which means that it's damaged, but it's able to function, or it's decompensated, which means it's damaged and it's unable to do all of its function, or at least some of the function is gone. Okay, so when it's compensated, you get different signs. So the liver is working. That means it's doing what it needs to do. It's enabling coagulation. It's enabling conjugation of bilirubin. It's doing everything that needs to happen. So the symptoms that you get is going to be more general. So you're going to get fatigue, nausea, anorexia, cachexia, because it's actually quite a huge catabolic burden when you've got liver disease. So they actually tend to lose a lot of weight. And a big focus with liver cirrhosis is actually getting them to eat. So when a patient presents with liver cirrhosis, actually the best thing you can do, especially when they've got alcoholic hepatitis, is to get them to eat. And you'll find a lot of these liver patients actually have NG tubes inserted just because they can't get as much energy as they need. You get spider nevi, pulmonary erythema, and gynecomastia. So I guess these signs are signs that you would see in anyone with chronic liver disease, not just liver cirrhosis. So when you think about a compensated liver cirrhotic patient, kind of think of signs that you would also see in a chronic liver disease patient that's not cirrhotic, because like I said, the liver is compensated. So then when you get to decompensated, that means the liver is just broken down. It's like the last injury has just knocked it off its edge. Okay, so you get signs like ascites and edema, jaundice, pruritus, easy bruising, again with the coagulopathy, and encephalopathy. Okay, so the last 5 things that you find in decompensated liver cirrhosis, it's so important. Every time you see a patient with chronic liver disease, you need to ask them that. Another thing that's not in there, another evidence of decompensation, is upper GI bleed as well. Okay, so when you get a patient with liver disease, I don't care what kind of liver disease they have, if they've got jaundice, I'm going to ask them, any swelling? Do you have any itchiness? I'm going to ask them if they're confused. I'm going to look for signs of encephalopathy, i.e. I'm going to check for asterixis. I'm going to ask them if there's any melena. I'm going to ask them if they've vomited any blood recently, okay? So you have to look for these signs, because when a patient's decompensated, it's telling you that actually they're a lot worse than they appear. And it means that you actually have to do a little bit more work on them, okay? So once I've seen my patient and I think they've got cirrhosis, I'm gonna wanna find out what's caused their liver cirrhosis. So every time a patient comes into, on the acute take, for example, I say, you know what, it looks like they've got cirrhosis, they've got evidence of jaundice, they've got evidence of ascites, what's the cause? So you take a full history, of course, and you do a full examination. That might indicate, show you a few causes. So obviously, like with hepatitis C, linked with patients with IVDU, they might have marks, track marks, they might have tattoos, you might look for evidence of a tremor with alcohol, things like that. And then you investigate, of course. So you do, you look for other causes, so autoimmune causes, genetic causes, drugs, and other causes of cirrhosis like Chiari Syndrome. So this is just something you need to learn, and you need to just figure out a way to sort of put them in groups that will become memorable for you when you actually get asked in your exams. Okay, so like I said, you want to investigate what's caused this liver cirrhosis. So you're going to do your liver function test, including gamma GT and albumin. We say that because not every liver function test actually comes with gamma GT and albumin. Albumin is important because it gives you a state of how well the liver is functioning, and also as you know, when you get low albumin in patients who are really unwell, so if it's really low, you kind of know that it's quite, again, like I said, a huge burden on the patient. You look for a full blood count, again, upper GI bleeds, of course, variceal bleeds, renal function tests. You can get hepatorenal syndrome in patients with liver cirrhosis. They're usually on diuretics, so you want to make sure your renal function is fine. And I think the really important question is, important point is, you can learn all these tests, but you need to know why you're doing the test, because they will always ask you, so why do you want the coagulation test? Why do you want to know the INR? So you need to know the test that you're going to do, and you need to know why. So you're going to check for hepatitis, CMV, which can cause a viral hepatitis as well, iron studies for hemochromatosis, alpha-1 antitrypsin gene, again for alpha-1 antitrypsin deficiency, ceruloplasmin, iron studies, other antibodies. You'd also do, so you've done your blood test, so you're going to do a Doppler ultrasound, and you have to specifically say Doppler ultrasound because you want to look at the vessels. That's because patients can get Chiari syndrome, which is a where you get a clot in the hepatic vein, hepatic vein, and this can, sorry guys, let me see what the chat's saying. This can lead to fluid, it can lead to portal hypertension basically, and subsequently edema and ascites. Okay, let me just see if there's anything else I wanted to say about Chiari. Oh yes, so with Chiari syndrome, when a patient comes in with a clot on the portal vein, you want to know what's caused the clot. So kind of like when a patient's got a new deep vein thrombosis, you want to find out if there's anything that's causing increased coagulopathy. So they usually go through a whole screen, and they might actually get a whole set of hematological bloods, including like things like lupus anticoagulants, just to find out if there's anything that's making them quite procoagulant. Okay, so, or procoagulable. Okay. Next up, so I'm not looking at the questions yet, guys, just because I'm sure if there's any issues, I will be told. So you want to look at the complications of liver cirrhosis. So your patients come in, they've got liver cirrhosis, you found out why they've got it. So you know whether it's alcohol, you know if it's hepatitis, you know if it's autoimmune disease, and then you just need to know a bit more about liver cirrhosis and how it impacts your lives. So when you've got liver cirrhosis, it's actually quite serious. There's a high mortality rate with patients with liver cirrhosis, but the complications are also what tends to increase their mortality. And you have to remember, these patients are actually really, really unwell. And I'm very passionate about that because there's so much going on. You know, they have the renal, they have the kidneys tend to go off, their heart doesn't work as well. They've got ascites, they vomit blood, they've got melena for GI bleed. They're very, very fragile patients. So it's really important to kind of be aware of the complications that they can get. So with the ascites, you can get spontaneous bacterial peritonitis, which is an infection of an infected, fluid in infected ascites, basically. And usually what you want to do is when a patient comes in with new ascites, no matter the cause, you're going to want to do a tap and get the fluid and then assess the fluid, looking for, of course, any organisms, but also you're going to look for other possible causes of the ascites because you don't know what the cause of ascites is. We're going to talk more about ascites later, so I'm not going to focus too much about it. Other complications, so you can get liver failure, so hepatic encephalopathy, which again is thought to be due to the gut-derived toxins that you get, these toxins that are normally supposed to be detoxified in the liver obviously aren't going to be detoxified because liver isn't working. So it bypasses the liver into the brain and you get encephalopathy. That's what they think is the cause. I think there's probably a few more other causes anyway. Coagulopathy, hepatocellular carcinoma. So every patient with liver cirrhosis tends to have 6 monthly ultrasound and 6 monthly alpha fetoprotein, which is a blood test measurement, just to make sure that they don't have any HCC. It's a very high risk of HCC in patients just for having liver cirrhosis. Some etiology of liver cirrhosis can increase your risk of HCC, such as hepatitis B. But generally, if you've got liver cirrhosis, you're going to want to check every 6 months if they have any increased risk of HCC. Other complications as a result of portal hypertension includes varices, hemorrhage, and renal failure, secondary to hepatorenal syndrome. So as you can see, there's quite a lot of ways that liver cirrhosis can affect patients, and it's important to know the signs and important to know the complications so that when a patient presents to you, you can kind of look for these signs in the patient, okay? A child Pew Score is a score that we use to predict mortality in patients with liver cirrhosis. So you can just say they've got a child Pew Score of 3 and everyone will kind of know what that means, although I always have to look it up anyway, but it's really good to know what scores they use. They also use the MELD score, and in the UK there's a UKL score as well, which can also be used to decide how unwell the patient is and how imminent their need for a liver transplant is. Okay. So our first question, a 63-year-old lady with a background history of liver cirrhosis secondary to non-alcoholic steatohepatitis or NASH presents to ED. She's got a temperature, a distended and tender abdomen, and her doctor suspects a diagnosis of SBP. So a TAP is performed to confirm this. Which of the following microscopy results is consistent with SBP? So I'll just give you a minute to think about it. Oh, there's a poll. Oh, it says hosts and panelists can't vote. Can you all vote?
Yeah, everyone's voting. I think it's just me and you that can't.
It's just us. Okay, fine. Good. Excellent. Oh gosh, sorry. Well, that's the answer, guys. I do apologize. So the answer is B, and I'll tell you why. So that's white cell count of 650 and 40% neutrophils. And I'm going to emphasize this part. That's the crucial bit, the 40% neutrophils. Actually, we didn't get to see the results. Should we see the results? Oh, well done, guys. Also, you know already. Well done. So yes. So ascites, again, like we talked about, accumulation of fluid within the peritoneal cavity. Due to portal hypertension. Why do patients have portal hypertension? They've got liver cirrhosis, the liver is stiff, and all this portal venous blood is just hitting this really stiff liver. Boom, you get back flu, you get increased hydrostatic pressure, etc., fluid everywhere. Okay, so you've got ascites in the abdomen and the patient comes to you and you think, you know what, they've got evidence of chronic liver disease. It could be because, sorry, that's not how you spell ascites, ignore that. But it could be due to the cirrhosis, but you have to be sure because you cannot assume that it's due to cirrhosis. It could, of course, be due to other causes of ascites, such as, let's say peritoneal metastases, for example. So you never assume just because the patient's got chronic liver disease that it's going to be ascites secondary to liver cirrhosis. But I mean, it's a good guess. So if you have a patient and they ask you, it's a good guess to say it's likely ascites secondary to liver cirrhosis. But what I would like to do is to do a abdominal tap to elucidate the cause of the ascites. And when I get my tap, I'm going to send that the fluid off for MCS or microscopy and cytology. I will also calculate the SAG, which is the serum ascites albumin gradient. And basically what you're going to do is you're going to subtract the albumin in the acidic fluid from your serum albumin, and that will give you a figure. So when you get a high SAG, it's due to these causes. So cirrhosis, heart failure, blood Chiari, hepatic failure, constrictive pericarditis. When you have a low SAG, then you're more likely to get things like TB or infections, cancer, pancreatitis, and nephrotic syndrome. So you just have to learn these. The way I think about it is I've got a high SAG, which means that the difference between my the fluid in the ascites and the fluid in my blood is quite high. That means there's a huge gradient, and there's a huge gradient that tells me that the fluid is probably less, there's probably less protein in the fluid, so it's less sticky and thick, so it's not going to be an infection. That's how I think about it. It's more like to be portal hypertension. So you just have to figure out a way to remember it. Okay, so next page, sorry, my thing's been a bit funny. So with SBP, it can occur in patients with ascites. It may present atypically. Sometimes they don't get abdominal pain, and that's really important because every single patient who comes in to your hospital with decompensated liver cirrhosis should really get an acidic tap as per guidelines. And that's because they mightn't get abdominal pain, and you don't want to miss an infected bag of fluid in the abdomen because it can really, really get them unwell. So you're going to do your tap and you're going to send it off, and you're looking for neutrophils greater than 250. So the trick of the question was that it said white cell count and then 40% neutrophils, which would be greater than 250. So that's why the answer was B. So it's always a trick like that with neutrophils. Patients with low acidic albumin are especially at risk and should be treated with prophylactic antibiotics. So you'll find that people are very iffy about prophylactic antibiotics, but usually we give it to them after they've had I think a second episode of SBP, and they get low dose Cipro. Okay, so next question. 52-year-old lady is referred to outpatient clinic with lethargy and pruritus. Okay, so she's got lethargy and pruritus. She's got some scleral icterus, abdomen soft, she's got a liver edge, and she undergoes a blood test as well as an abdominal ultrasound. Which of the following is the most likely diagnosis? So you've got PSC, autoimmune hepatitis, PBC, Wilson's, and paracetamol overdose. And don't forget, you've got a list of investigations there that I'm not going to read, but hopefully will give you a hint as to what the right answer could be. Okay, I'm going to say, let's see what you guys have chosen. You've all said C. Okay, so the answer is C. Very good, guys. So this is based, so you've got, this patient's got evidence of chronic liver disease. HB is normal, that's not going to tell you. White cell count's normal, that's not going to tell you much. Platelets 320 tells you that she's actually doing pretty well. CRP is less than 4. Everything else is fine, slightly raised, fine, a bit low, raised, and this is the money. So they've got anti-mitochondrial antibodies, M2 subgroup, which is positive, and that is usually seen in patients with PBC. So it's just worth knowing that. Again, you just have to remember. Wilson's disease, you probably see evidence of increased copper, low ceruloplasmin, paracetamol overdose. You're not really going to see much. You might get an AKI, obviously really, really deranged liver tests. You wouldn't really get, well, you could get a liver edge, I guess. They'd be really confused. And then obviously the age, 52 as well, makes you think PBC. PSC, you can get PANCA, SMA, but it's a bit more, it's not as specific as a PBC with the AMA, but ANCA is one that you look for. So you just need to, and autoimmune hepatitis as well. So you just need to like know these autoantibodies basically and just learn them. Okay, next question is 67-year-old man He's got cirrhosis, secondary to alcoholic liver disease, comes to the ED with hematemesis. He's unstable, he's tachycardic with a heart rate of 120 and his blood pressure is 100/60. He's treated for a variceal bleed with IV fluids, aiding to blood and antibiotics. He's got an OGD listed for tomorrow. What is the most appropriate medical treatment before his OGD? What would you give him that would make a difference? Telepressin, omeprazole, ursodeoxycholic acid, octreotide, and Pabrinex. Okay, sorry guys, I have to rush through it a bit because we've got a few questions to do. So you guys have all chosen telepressin. Well done. Good stuff. Yes, the answer is telepressin. We don't give omeprazole. It's a variceal bleed. It's not really going to do anything really. So telepressin reduces the portal pressures, which means that it reduces the pressure, obviously, in the esophageal varices themselves, which are the problem. Which is the problem in this case. That makes sense? So telepressin is going to reduce the pressure. There's a lot of, so imagine the vessels, the esophageal varices are literally spurting. You reduce the pressure, boom, it should hopefully improve the bleeding. Omeprazole we use if they've got duodenal ulcers, orsodeoxycholic acid using cholestasis. Octreotide we don't use, although I've seen a few papers that have discussed the use of it, but we don't use it. And Pabrinex you give in patients with ALD. Why do we do that? Because the increased risk of having B12 deficiencies, and you don't want them to have Wernicke's or Korsakoff's. So every patient with alcohol excess, not just alcoholic liver disease, tends to have Pabrinex. Okay, and always check the glucose as well. Grand. Okay, next one. 73-year-old lady comes to ED with 2 days of feeling generally unwell. She's got abdominal pain and having temperatures. On examination, she's pyrexic, jaundice, abdomen is soft, tender in the right upper quadrant, and her bloods are shown. What is the definitive management? Definitive management. MRCP, IV antibiotics, ERCP, fluids, endoscopic bland ligation. Definitive management. Okay, we're good. ERCP, very good. You guys are good. Honestly, you're doing so well. I mean, why am I here? So yes, ERCP. So basically, so what is actually, can someone put in the group, what's the diagnosis? What does she have? Just one answer. Yes, thank you very much. She's got ascending cholangitis. And it's really, really important that you recognize it. So it's that classic triad. She's pyrexic, she's got right upper quadrant pain, and she's jaundiced, okay? So it's straight in there, IV antibiotics, IV fluids. Those are good answers, right? But the definitive management, once she's a bit more stable, is an ERCP. And basically, it's a concept I'm sure you know already. It's all about source control, okay? The microbiologists love saying that. You can throw antibiotics as something you can throw antibiotics at someone who's unwell, but if you don't manage the cause, you never really manage the patient, okay? So they love that source control. So if you've got someone who's got like an abscess or something, and it's well and good giving them antibiotics, but you've got this massive abscess in the stomach, they like to say source control. So what they like is for you to get in there and get the abscess out. So it's same with this case as well. So this patient's maybe got a gallstone in there that's obstructed, her CBD, and now she's got loads of bile, loads of backflow, loads of infection, you know, antibiotics, the microbes love the bile. And then you can give antibiotics, which is all great. You should give antibiotics, but you're not going to manage her without ERCP to get in there, dilate the bile duct and release all the obstructed bile, basically. So everyone usually gets an ERCP. Who do you call for an ERCP? Who's your person? Someone said, why is this not MRCP? So an MRCP is not IR? No, it's not IR, guys. So MR, gastro, thank you. Yes, gastro or hepatology, depending on the department, gastro. It's not MRC, and MRCP is just imaging. It's just imaging. It's not going to do anything. So it'll tell you that you've got dilated bile ducts, but it's not going to treat you. So it's really not useful at all. In fact, you go straight to ERCP because you don't even need the MRCP. You do the ERCP because the ERCP gives you the images as you're treating them, okay? So yeah, so that's that one. Good, you guys are doing really well. So you've got a 28-year-old lady, background history of ulcerative colitis, so we've moved on from the liver a bit. Comes into ED with bloody diarrhea. She's got normal oral mesalazine, topical mesalazine to control her UC. She's feeling unwell for a couple of days. Bowels open 8 times a day. Abdomen is soft, mildly tender in the left iliac fossa. She's got no signs of peritonism. She's got a temperature of 38.5. A doctor thinks she might have a flare-up of her UC. What is the most appropriate management for this patient? Do you want to discharge her home with oral antibiotics? Do you want to give her some infliximab? Do you want to discharge her with oral steroids? Give her some IV steroids, or do you want to just reassure her and discharge her? What do you think is the best option? Okay, we can go to the next one. So you guys have chosen D, 82%. Well done. Okay, great. So you're correct. You want to admit her and start her on IV steroids. Why? This is why. Okay, so this is the True Love and Wits criteria. You have to just know that. It's the criteria that you use for any patient who presents with ulcerative colitis to decide how you're going to manage them. If they've got severe ulcerative colitis, which is this bit, and this is when, and it's usually if there's a patient who might have severe ulcerative colitis, this is the type of question that presents. They come in, they're pyrexic, they're tachycardic, they've got all these lovely, lovely signs that pushes them up to severe. And once they get into severe, then you just give them IV antibiotics, and then that's IV steroids, and they need to be admitted. And then you call the gastroenterologist and you say, hey, we've got a patient here with these signs, what would you like to do? And then yeah, that's it. So bowel movements, 6 or more, visible blood, pyrexic, tachycardic, anemic, which and above 30. I didn't actually see what the ESR was. Probably was a bit high, wasn't it? Oh, we didn't say that, but yeah, but she's already met the criteria anyway. Okay, so True Love and Wits criteria. It was mild. You just give some. You might not even give steroids. You might just give some mesalazine, but she wouldn't come to the hospital, would she? If it was moderate, you might be able to get her with some oral steroids, actually. Again, the question said that she'd gone past oral steroids anyway. So it was always going to be IV steroids, actually, when you think about it. Okie dokie. Let's see where we are next. So we've got a 28-year-old lady. So I'm just going to try and get through all the questions, and then I will look at all the questions later. 28-year-old lady presents to her GP with diarrhea and weight loss. She's got some routine bloods to investigate this, and which has shown that she's anemic. So she's 28, she's anemic, she's got diarrhea and weight loss. She's got an itchy raised red rash on her elbows. Given the most likely diagnosis, what is the gold standard for diagnosis? So is it a total IgA and IgA TTG, HLA-DQ2 and DQ8 testing, colonoscopy, endoscopy with duodenal biopsy, and a fecal calprotectin? So I guess with this one, you kind of need to know the diagnosis as well as how you would investigate. But you can kind of figure it out, I think. I'm sure you guys will. Okay, let's see what the correct answer is. Ooh. Oh, this is good. Finally, I was waiting for something a bit dramatic. Okay, so the answer is, it's D. So I guess the first thing is, the question is, well, actually, let me just go back here because it says it's changed, but the question is, what's the gold standard? So this patient has, what does the patient have? What do you guys think the patient has? Yes, okay, so they've got celiac disease. Thank you very much. So you all know why. I don't need to explain that. Someone said, is it not jejunal biopsy? So I said this once to my consultant, is it not a jejunal biopsy? So it can be a jejunal biopsy as well. But they usually say duodenal biopsy, and I think it's probably because it's easier to get to your duodenum rather than a jejunum. But jejunal biopsy is absolutely correct as well. It's just not part of the question. Why is it not A? It's just not the gold standard. I'm sorry. Obviously, when someone comes into clinic and you think that they might have it, you're going to do all these tests anyway. And absolutely, you know, if someone came with a TTG, I'd think, oh yeah, it could be celiac. I'd do a TTG, but the gold standard, and it's a classic question, and you just need to know it. It's endoscopy with duodenal biopsy or a jejunal biopsy. Why do we do an IGA? Does anyone know why we do IGAs before we check TTGs? And why do we care about IGA deficiencies? Yeah. So if someone's got exactly false negative, exactly. So if they're IgA deficient, it might not be exactly. Okay, you guys are on it. DQ2 and DQ8 is associated with celiac disease, but again, it was all about the gold standard. Colonoscopy, not useful. Fecal calprotectin, good for IBD, not in this case. The answer is D. Okay. If you disagree, you should email in and then but yeah, that's the answer. Right, so features of celiac disease, just something to quickly go through. So they get malabsorption, flatus, steatorrhea, anemia, vitamin deficiency, linked with lymphoma and carcinoma. So try and remember that. Again, like we talked about, immune associations, IgA deficiency, type 1 diabetes, PBC, anemia, and this is a classic question. And this was really the clincher, wasn't it, really, in that question? The fact that they get dermatitis herpetiformis, which is seen in celiac disease. Okay, next question. Let's see. 62-year-old gentleman presents to his GP with worsening constipation over the past few days. On examination, his abdomen is soft and non-tender. He's got a routine set of bloods that's shown iron deficient anemia. Which of the following is the most appropriate way to investigate the cause of his symptoms? Do you want to do an urgent CT, chest, abdo-pelvis? Do you want to do a non-urgent referral for a colonoscopy, an urgent referral for colonoscopy, fecal occult blood testing, or start on high-dose laxative and review in 6 weeks? I feel like this could be contentious as well, so we'll see. Okay, let's see what the answer is, or what you guys have chosen. Ah, guys, you got it right. Well done. So yes, you get an urgent referral for a colonoscopy. So it's not, that's just the guideline. So basically what I would do is actually, and I do this myself when a patient comes in with iron deficiency anemia, I go to the NICE guidelines. It's got really CKS NICE guidelines. And it's just got a really nice paragraph there about when to refer and to whom. And that's because with the ages, you actually, sometimes you forget, is it 55, is it 60, is it 65? So it's just really good, just have a look at it and see. So that would be the ideal thing. 60-year-old gentleman, altered bowel movements in the past few months, and now the iron deficient anemia. You want that urgent 2-week wait because you're worried about colon cancer. Okay. I mean, yes, this could show you that he's got colon cancer, but it's not definitive investigation that they want. This is definitely not right. That's too long. This may or may not be positive. And you don't really need this because you know he's got anemia, so you just need to get in there and send a 2-week wait referral, and this is definitely not the right answer. Okay, so we've got a 55-year-old lady with known non-alcoholic steatohepatitis or NASH, cirrhosis, admitted with worsening abdominal pain and abdominal and leg swelling. On examination, she's got a slightly distended abdomen, pitting edema in her legs up to her knees. She's apyrexial, inflammatory markers are normal. They suspect she's got ascites, secondary to liver cirrhosis, and decide to put her on a food restriction to start her on a diuretic. Which of the following diuretics would you use first? Furosemide, bumetanide, benzoflumethiazide, acetazolamide, or spironolactone? Okay, let's see what the answer is. Contentious. Do you know what? Sometimes I always have to ask gastro this as well, sometimes as well. But if they've got ascites, you should go with spiral first. That's how. So that was what someone said to me. They said, if you think they've got ascites, then you should give them spironolactone. If it's just peripheral edema, some people give furosemide, but the right answer is spironolactone as per guidelines. So if you went to the guidelines and you searched what is the first line treatment for ascites, diuretic treatment for ascites, it's spironolactone. And then you can add furosemide. If you've up-titrated the spironolactone and you're still not getting adequate diuresis, then you add furosemide. Okay, so that's how it works. What are the side effects of spironolactone? You kind of need to know these. So if you can just throw like one or two side effects. Is it hypo or hyper? Yeah, it's hyper. Excellent. Gynecomastia. Perfect. Why did I ask? Well done, guys. Okay, good. So that's just for you to remember. Again, this is a specific case, obviously. It's liver cirrhosis with ascites. Okay, grand. So you've got a 21-year-old lady. She's been investigated by her GP for long-standing history of abdominal pain, bloating, and intermittent diarrhea. These are her investigations. What do you think the most likely diagnosis is? Gastroenteritis, IBS, bowel adenocarcinoma, celiac disease, or IBD? Someone said, why spironolactone? I think it just works better for ascites. Genuinely. I'm sure there's a more clever answer than that, but it's just literally what they use. First line for ascites, liver cirrhosis. Okay, so should we see what you guys have chosen for this question? You've all said B. Yeah, it is. It's not E. Her fecal calprotectin is normal. Everything's normal. She's got all these symptoms, but everything's normal, and it's IBS. If her fecal calprotectin was high, then you'd consider IBD. And as you may know, fecal calprotectin is a protein that's produced when there's inflammation in the bowel. It doesn't mean it's necessarily IBD. It could also be an infection that raises your fecal calprotectin, but at least you'd know there was some inflammation in the bowel. Hence, the answer is IBS. Okay. You've got a 65-year-old man with cirrhosis secondary to ALD. He's had multiple admissions with ascites, requiring regular abdominal paracentesis. He's planned to have a transjugular intrahepatic portosystemic shunt or a TIPS procedure for his refractory ascites. Which of the following is he most at risk of developing after his TIPS? So is it A, variceal bleed, hepatic encephalopathy, Patro-renal syndrome, SBP, or jaundice? So which of these answers will cause a complication? No. Which of these is a complication of TIPS? Thank you. Okay, let's see your answers. Yeah, the answer is B. So this is a classic question. You just have to know it. Every time someone even comes into that, every time someone's been considered for a TIPS, we have to look for signs of hepatic encephalopathy. And we don't only look for signs of hepatic encephalopathy, we also look for a history of hepatic encephalopathy, and then they make a decision as to whether or not the patient will get a TIPS. And it's really important because the last thing you want is to try to improve someone's life with their ascites, and then you cause them to have, grade 2, grade 3 hepatic encephalopathy, and they can barely move, and it's just like comatose, and it would be really, really sad thing. So we do a really, really thorough history, and we make sure that everything's normal before we try and at least reduce the risk of it, of post-TIPS HE, but they can still get it anyway, even if they've never had a history of hepatic encephalopathy. Okay, so it's just something to know. So this is I just wanted to give you an idea of what the shunts look like. Not that I've ever actually seen one. Who does this? Okay, so who would you refer a patient to get a TIPS done? Who would you call? Yes, you call IR. Someone said diagnosis of exclusion. It's not a diagnosis of exclusion. It is a portent risk post tips. You just look for it. So it's the radiologists who do it, although there is one or two, I do know one or two hepatologists who do tips, but it's very rare. But yes, so usually they put a stent in from the portal vein through to the hepatic vein there, and you hope that it will help the blood to just kind of bypass all this awful scarring and hopefully help hold the pressure. But obviously with bypassing straight from the portal vein into the hepatic vein, it is thought that all this bypassing stuff causes all these toxins, again, all these gut-derived toxins to get straight into your bloodstream, boom, into the brain and get hepatic encephalopathy. But it mustn't be the only reason because not everyone gets it. So I can't really answer that one for you. But yeah, so it's just a high risk. Right. 32-year-old woman with Crohn's disease is seen in gastroenterology outpatient clinic. She's discharged from hospital 10 days ago with a flare-up of her Crohn's colitis, which was managed successfully with high-dose IV steroids and was weaned to oral steroids, okay? So she's recently discharged after a flare of colitis with IV steroids, weaned to oral steroids. Which of the following would she be started on to maintain remission? Methotrexate, azathioprine, infliximab, metronidazole, and mesalazine. Okay, shall we see answers? You mostly said azathioprine. Some people have said mesalazine, and some people have said A. Okay, so I mean, so it's B because this patient is required IV steroids and under oral steroids, and you're going to maintain. That tells you that if they're required IV steroids and oral steroids, it already tells you where on the algorithm they are. They are in at least moderate to severe. Okay, so you're gonna, that pushes off the mesalazine. Mesalazine is just not gonna. We're just not interested. We're just not interested. Okay, because the patients move beyond that. Okay, boom. Then they're on steroids, but you don't keep patients on steroids. That's something with IBD as well. And any long-term chronic disease, you just don't want to keep patients on steroids. So they should always have alternatives. And that's a classic thing in IBD, because if someone's steroid dependent, that means, anyway, I'll come back to that. Right. So the patient's on oral steroids, and they've required IV steroids, so they're at least moderate to severe. And when you want to maintain remission in that group of patient, it's usually azathioprine. That's the first line. If the patient's not tolerating azathioprine, then you can consider methotrexate then in Crohn's disease, okay? If a patient is on azathioprine and is still on steroids, and every time you try to get them off steroids, they get a flare-up, or as we call them, they are steroid dependent. So that's one set of patients. And then you have steroid refractory patients who are, despite steroids, still having flare-ups, okay? So you've got steroid dependent, you can't get them off the steroids, or steroid refractory, despite steroids, they're still having flare-ups. Then you consider the MABs or infliximab, which is an anti-TNF monoclonal antibody. Okay, and then metronidazole you don't really use except if they've got like complications like a fistula or something like that. Then you would use it. So I hope that makes sense as to why. So it's just azathioprine would be the first line. Okay. 7-year-old girl is brought in by her mother to see her GP about some freckles that she's noticed on her lips, hands, and feet. No past medical history. Family history, mother reports she has no contact with her father, but remembers that he had similar freckles and the paternal grandfather died of gastric cancer. In examination, she's got pigmented lesions on her lips, oral mucosa, palms of her hands, and soles of her feet. What is the most likely diagnosis? So is it hemophilia A, Plummer-Vinson syndrome, HHC, ITP, or Peutz-Jeghers syndrome? Okay, I'm gonna just look at this one because I feel like you either know it or you don't. So you've all chosen E, but some people have chosen C. Okay, I think, so the answer is E. She's got Peutz-Jeghers because she's got these, you get these pigmented macules or freckles. They call it freckling sometimes, I guess, in the books. And the reason it's in your GI SBA finals lecture is because you get an increased risk of polyps, and no, you get polyps, and the polyps increase your long-term risk of having cancer, inherited familial disease, autosomal dominant, hence you can see the history up to the paternal grandfather. It's not HHT. HHT, you get telangiectasia, you don't really get the macules. You get AV malformations, you get GI bleeding, epistaxis, yeah. And then you've got ITP, hemophilia A, Plummer-Vinson syndrome, where you can get iron deficiency anemia, esophageal webs, dysphasia. Okay, so just Peteger syndrome. I'm just gonna have to know that one. And it does come up, and it does come up, and it does come up, and it comes up when you're studying for PACEs as well. So it doesn't ever, this is worth noting. Okay, so 76-year-old man comes in with worsening jaundice, intermittent abdominal pain, and weight loss. He's got no significant past medical history. He's jaundice, he's cachectic, he's got a non-tender mass in the right upper quadrant. Which of the following would be the most useful investigation to establish the diagnosis? Do you want a CT abdo, AFP, bilirubin, ultrasound, or MRI? Okay, let's see what you guys have chosen. Okay, most of you have chosen A. Not a lot. Some of you have chosen ultrasound. MRI. Okay, I guess what you need to do is figure out what you're looking for. I mean, what's the most likely diagnosis based on your on what they've just written to you? I think that's where you start off. Yeah, he's probably got pancreatic cancer, hasn't he? I mean, the ultrasound. Why wouldn't we use the ultrasound? Who knows? Why is ultrasound not going to tell you whether or not this patient got pancreatic cancer? What's that thing that they always tell you about ultrasounds and how much can be visualized by your ultrasound? Did they say that? Yeah, I don't know, did they tell you that? In medical, they always say you can never see the distal portion of the common bile duct with the ultrasound, and you can never see where it joins up with the pancreatic duct. So it's not good enough. It's not good enough when you've got dilated CBD of any length, because the ultrasound might tell you, okay, fine, you've got dilated CBD, but you can't see all of the CBD, so you miss stuff. So even if you do an ultrasound, it's like, yes, great, he's got a dilated CBD. What now? Then you're gonna have to do further imaging. Okay, but this guy, even though you think he's got pancreatic cancer, he's got all these hallmarks of cancer. Okay, so I'm going to want to do a CT scan, because it's going to help me visualize not just the pancreas, but everything around. Because even though he's jaundice, maybe he's got some liver mets, maybe he's got a few things. So I would do a CT initially to start off, and then take it from there. Okay, and then after that, then you obviously discuss with the gastroenterologist, and you have an MDT, and decide on they want further imaging, and maybe they'll want, maybe they will want an MRI, because maybe when you do look further, you realize this person doesn't actually have pancreatic cancer, but they've actually got evidence of biliary stricturing, and maybe they've got PSC, so then you might do an MRI. What would differentiate the history from cholangiocarcinoma? I agree with you. That's what I was just about to say. Like it could be a cholangiocarcinoma, absolutely. And I know what you're thinking, because then why not do an MRI? But I think I would just. Sorry, I lost my train of thought because I was reading everything. But we would just do a CT abdomen, because there isn't no clear diagnosis. And it's very rare that you would just go straight for an MRI or an MRCP without doing an ultrasound. But I wouldn't do an ultrasound in this case, because he's got so many systemic features of what is probably cancer. So I would start off for the CT. And the CT is just a really good overarching image that will capture most things. And then if you want something finer, you might consider further imaging like an MRI. I hope that didn't confuse you. But he's got worsening jaundice. He's got intermittent abdominal pain and weight loss. He doesn't, I guess it's, when it's painless jaundice, I think they mean more like he doesn't have right upper quadrant pain. He's got some abdominal pain, but that abdominal pain is literally anything. And you might just get abdominal pain. Maybe he's got some metastases or something. It could be due to that. Would a cholangio present with a mass? Probably not, actually, you're very right. But then again, maybe you've got cholangiocarcinoma, you could have some cholecystitis with that, you can get some empyema with that. You never really know, I suppose. And I suppose that's what the question is. You just need to figure out what you're looking for. You know that you're looking for cancer and you're going to want a CT scan. Okay, so I think that's that. And there's a few images. I'm going to pretend I'm a histologist, but I'm not. When do you do an endoscopic ultrasound or an EUS? Ooh. So I think they do an EUS to better visualize. So you've got a CT scan and it looks like there's a pancreatic CA. They usually do an EUS to better visualize for local invasion at that site. And then also sometimes you can do an EUS to actually get biopsies as well. It's a whole amazing thing. So depending on where it's localized, an EUS can help you get a biopsy. But that's it's very niche. It's very MDT led as to when you do an EUS, but usually it's for local invasion and it's CT scan. And then once you've done the CT abdomen and it looks like they've got cancer, then you definitely want to do a CT chest abdo-pelvis because you want to make sure there's nothing else. Okay. So this is what is probably some pretty, I'm not a histologist, I'm going to do my best, yeah. But there's some polyps here and evidence of long-standing inflammatory bowel disease and some hemorrhage. I don't think this is going to come up in your exam, but just to have a look. This apparently is Crohn's disease. I don't even know why. I'm just letting you know that this is Crohn's disease on histology. I don't even know how I learned it in med school. We just look at these. So this is, I'll read this because I've got it's got some atrophy of the villi. Trust me on this. You've got some crypt hyperplasia. And you've got some intraepithelial lymphocytosis. So when you put all that together, apparently this is celiac disease. And then this is Barrett's esophagus. So I'm just telling you things that you should probably just be aware of that we would do biopsies for. So Barrett's is very important. It will always come up. It came up in my PACEs. Okay, something that we care about. So please learn it. Did I get questions about histology in med school? I mean, there was one module that we did, but not in finals. But all med schools are not made alike. So if you're just find out in your med school if they do histology, and please definitely learn it as best as you can. Dysphasia. So what if I say iron deficiency anemia, dysphagia, and esophageal web? What's the diagnosis? I think I said this already, but just to reiterate. Excellent, great. And just one of those things you have to learn. Okay. What about this? What does this patient have? They've got a dilated esophagus and a bird's beak. Perfect. Okay, you guys are ready. What about this? What do you think this is? Toxic megacolon. What are the causes of toxic megacolon? Yes, you see C. diff. Yes, yes. Ischemia as well. Diverticulitis? I don't think so, because it's not really going to cause an obstruction. Don't quote me on that, but I don't think so. You can get, there's one more. C. diff. Oh no, I think that's it really. C. diff, IBD, yeah. I think we mentioned most of it. Very good, very good. Okay, and what about this? What do you think this is? What would you, okay, if the patient's got abdominal pain and melena, what are you thinking? Okay, how are you going to treat them? Surgery? Would you immediately call the surgeons? Yeah, I would. I would, Grace. I would. I'd call the surgeons as well. I'd call everybody. And if they're really unwell and they're unstable, I would put out a 222 call and get everyone there with me. I would put some IV cannulas in, get my fluids, get my blood, 2222, get your hemorrhagic call out, get your 4 units of blood, get your FFP, get everything, because you need all hands on deck. Do not manage this by yourself. You just call everybody. Okay, very good. Surgery. Never forget the surgeons. Yeah, you're right. And this is obviously not the only cause of a perforation. Of course, the other cause is for duodenal ulcer. And yes, there are other managements for duodenal ulcer, absolutely. But once they've perforated, you know, the game's changed, hasn't it? So yeah, so we would do PPI, we would do endoscopic banding is for variceal bleeds actually. So you band the varices, but with duodenal ulcers, you give them adrenaline, and there are other things that you can do, and hemospray as well. For banding specifically is for varices, because that's what you can band. You can't really band an ulcer if you think about it. Okay, very good. Gallbladder disease, Ghostbusters. Gallbladder, we have 6 minutes. Gallbladder disease. I just want to highlight things that you should know and be aware of. So do not go into your exam not knowing, except maybe this, because I don't really, I mean, vaguely I'm aware of that, but and maybe this as well, but this, do not walk into your exam without knowing what this is, without knowing what this is, without knowing what this is. This makes you sound really smart. This one is really rare, never happens, but you should know it. This, you have to know it. This, if you walked in there and you didn't know what ascending cholangitis was, just walk out again. Empyema, of course, it's just a complication of cholecystitis, just something to be aware of that can happen. And of course, pancreatitis, you're not going to walk in there without knowing what pancreatitis is. You're going to know what your scores are, the Glasgow-Imrie score. You're going to know your investigations, pancreatitis. You're going to know complications of pancreatitis, pseudocysts, etc. Yeah, pancreatitis is a big one actually. And you do actually see a lot of pancreatitis in medicine. You see a lot, especially when you're surgical, just pancreatitis, gallstones, appendicitis, and you just kind of cycle through them. And that's why this page is very important, because we see a lot of it, and everyone actually really, really needs to know this. Okay, this is just so that you're aware that you should be you should know the inherited familial cancers as well. So you've got HNPCC, you've got APC as well. No, you've got APC, you've got familial adenomatosis polyposis, and the gene is APC. So try and learn, your genes as well, mutation of mismatch repair enzymes. You should try and know this rule. So that means that, so you get these cancers, so you should have more than or equal to 3 family members over 2 successive generations with at least one of these cancers less than 50. You just need to know that. Yeah, that's it really. And your causes of jaundice. Okay, so you kind of split it off in your head. Just when you go into your exam, just know how you're going to split up what the cause of jaundice is, because they will ask you what are the causes of jaundice, and you just don't want to walk in there without knowing that. So before you get in there, just have it in your head. This is one way to present it. There's so many other ways that they've done that online. So just find one that works with you and that sticks in your head, and then just learn it, and that's it. What's the score for pancreatitis? So there are many scores, but we like the Glasgow-Imrie score for pancreatitis, and it tells you the severity of the patient's pancreatitis and whether or not you need to get ITU involved. That's what the point of the score is. Okay, so if I think it's over 2, you just call ITU and say this patient's quite unwell, because they actually really get unwell, and a lot of them actually end up with quite severe consequences and hemodynamic instability. Okay, and that's everything. Got 3 minutes if you have any questions. Please fill out the feedback. It helps us to kind of know what we're doing and whether or not we can improve in any way and what we can do to make the session better. And yeah.